Hi, everyone. In part 3 of our pharmacological series, Aaron is going to talk about medications that work on the brain and nerves. First, we will go over a variety of sedatives that you will see and use in transport. Most of these should be familiar to you at this point. Then we'll talk about anesthetics, which are medications that are used to render a patient unconscious. We'll review some of the antipsychotics that your patients may have received before you show up, and some that you may actually give. And then we'll discuss a variety of analgesics, from narcotics to non-narcotics. After that, we'll hit anticonvulsants. And finally, we'll go over paralytics, which may be new to you, but you will need to become very comfortable with these. Let's get started.
There are many central nervous system medications that are used during transport. These include sedatives, anesthetics, analgesics, and anticonvulsants. Anesthesia essentially stands for being able to induce a state of unconsciousness in a patient, whereas analgesia provides pain relief or pain reduction. And then finally, anticonvulsants are supposed to provide a termination of seizure activity, both from convulsant and non-convulsant seizures. Probably the medication you're going to use the most often is the class of benzodiazepines. Benzodiazepines actually bind a receptor to prevent the release and action of the neurotransmitter GABA. Midazolam is the first of the benzodiazepines we're going to talk about. The indications include using it for conscious sedation, as an anxiolytic. We had used it in the past for rapid sequence intubation induction, although we don't use it as much for that anymore because we have other agents. Terminating status epilepticus, and using as amnestic. It's a very rapid onset when compared to other benzodiazepines. It says 3 to 5 minutes when you look into the packet insert, but it's really within a minute. Dose ranges depend on the indication, actually. It can be anywhere from 0.5 milligram to 5 milligrams. I would recommend pushing this slowly to avoid hypotension. Being really aggressive about the dosing, especially in status epilepticus, at 0.2 milligrams per kilogram with a max of 10 milligrams is important. Giving little to aliquot doses of this medication when someone's seizing is not going to help them. We also use it in combination with analgesics for pain control. And it's not because it's a pain reliever, it's because it takes away the anxiety of when you are going to feel pain again. And so it kind of takes away that circular down drain feeling of pain. I would caution using this in patients with renal failure because they can have prolonged and or very extreme sensitivity to this drug. So just in the past 2 months alone, I've had at least 3 patients come in from transport with too much midazolam on board. And that means we either had to watch them for the next 4 hours to see if they're going to maintain their airway or not, or we've intubated them because we didn't have the resources to provide them with one-to-one care when nursing.
Now, what about using this drug as a chemical restraint? Because it does happen out in the field, and it's usually not IV.
It's usually not IV. It depends on what route you're using. Intranasally, about 85% of midazolam is absorbed intranasally. So I would consider, if you do a 5 milligram push, getting 3 milligrams is actually pretty decent. That being said, you have some extremely combative people out in the field. When you're giving it intranasally or intermuscularly, it takes a long time to work. And that's one of those things about knowing about the onset of action of these medications. When I have discussions with medics afterwards, like, why did we push 10 milligrams total? Well, I gave 5 and it didn't work, so I gave 5 again. I'm like, well, how soon after? Like, I don't know, a minute. Well, you didn't give a chance for the drug to work. That being said, I want our medics and our first responders to be safe in the field. We can always manage airways. It's a situation where you're in a rural area and you don't have airway management skills. So that's where it kind of gets a little trickier. The other thing about in the field for chemical sedation is that alcohol is usually one of the major reasons people are very combative. When you put a benzodiazepine on top of alcohol, you are severely depressing their CNS and you're causing respiratory depression as a very likely perchance. So use your drug, know your onsets, give it time to work. If you're in an unsafe situation where you're afraid for your safety or the patient's safety, you may have to manage airway in the meantime. Diazepam is also another benzodiazepine that we use as an anxiolytic. It's also a great muscle relaxant. We will use it in some patients for terminating status epilepticus. Some homes actually keep it as a rectal gel for patients with really severe seizure activity and for alcohol withdrawal. It is slower onset compared to the other benzos, but it does work really well for alcohol withdrawal when lorazepam's not working. Dose ranging is kind of subjective to age, renal function, indication. But the biggest thing I want to kind of bring off of this is we just talked about diluting medications. Do not dilute diazepam. If you dilute it with NS or D5, you'll actually precipitate it out. The drug won't work. It's just a cloudy, chalky mess. So don't actively dilute it. That being said, you're going to be putting it into an IV line that has, saline in it, for example, or saline locked. The trick of it is get the drug in, flush it quickly. Don't let it sit and just become a chalky, blocked up mess. Lorazepam is a pretty heavily used benzodiazepine, both orally and intravenously. You can actually give it IM too if you need to. It's actually our first line treatment for terminating status epilepticus. Unfortunately, most rigs can't carry it because it requires refrigeration. We also use it for alcohol withdrawal and as an antiemetic. Lorazepam is longer acting than diazepam, and some of the bad things about it is it does contain ethylene glycol. If you ever heard of any of the toxic alcohols, this is one of them. This is kind of tricky because we used to do continuous infusions of lorazepam. We don't really do that as much anymore. But high doses, particularly in patients with renal insufficiency, can lead to ethylene glycol toxicity. Dexmedetomidine is one of my favorite drugs. It is a selective alpha-2 adrenergic receptor agonist. It actually is a more potent IV cousin of clonidine. We use it to either reduce opioids parasurgically, so the anesthesiologist may use this, or we use it for post-intubation sedation. The initial FDA indication for this was to try to wean patients off of medications like propofol or continuous infusion benzodiazepines to let the patient have a better respiratory drive for the aiding of extubation from a ventilation situation. Dosing is very artistic. It can be anywhere from 0.5 mics to 1 microgram per kilogram per hour for 10 minutes. And then you would change it to a maintenance infusion. So it's kind of like a quasi bolus, and then you would move to a maintenance infusion. Loading doses can be withheld if they're already on other sedatives. It's only really to kind of get you into the hole. That being said, because it's alpha-2 adrenergic receptor agonism, it can cause profound hypotension and bradycardia. So it's one of my favorite drugs because it could work, but it could work so well it could hurt you. Every pharmacist has that one drug that you're just like, man, if it really worked well, it'd be fun. But then you have all the reasons that still be involved with it because it could have some toxic effects. Propofol, also known as milk of amnesia. Really, propofol is a really poorly understood mechanism of action. Most camps talk about it having GABA effects like benzodiazepines do. We use this for induction or maintenance of anesthesia. We can use it as a sedative for intubated patients post-intubation. We use it at high doses for refractory status, and we've also used it for procedural sedation. Anesthesiologists actually will use this as their induction agent for intubation. A lot of the transport and emergent intubation situations in the field don't really allow for propofol to be used, but it's something that is used out there.
We carry it, and the only time I've ever used it is typically when they are on it. When we pick them up from the hospital, we'll just continue it. I've never used it for induction. We have other drugs that are better, but as far as maintenance goes, it is a great drug.
So in terms of maintenance and continuous infusion, the dosing can be anywhere from 5 to 50 mics per kg per minute. The listed maximum is 80 mics per kg per minute. Personally, I don't like going anything above 50 mics per kg per minute. You can titrate every 5 minutes in increments of 5 to 10 mics, and you can bolus for severe agitation. But the thing about this medication is it can cause profound hypotension. It may actually be rate limiting in terms of whether or not you can use it in your patient in shock. Propofol is very short acting, so it allows for sedation vacations to see if the patient is able to work on their own ventilation, and also can allow for neurological assessments. Now, when I mentioned that my personal max is around 50 mics per kilogram per minute, if I still have an agitated patient at that point in time, it's probably because we're not providing analgesia. They probably need some fentanyl. They probably need some hydromorphone. They need something because pain will always override sedation.
People, and I see this a lot in the hospital, especially outside facilities where they're not like super up to date on stuff, or they don't see these types of patients a lot. Sedation is not analgesia. And if you have paralyzed somebody and intubated them and they're on a propofol drip but no fentanyl, and it's a trauma patient, you are torturing this patient. It's like, I would imagine it's like being in a bad dream that you can't wake up. I hurt so bad, but I can't wake up. Always when there's pain involved, intubating hurts, but traumas, things like that, make sure that you have an analgesic on as well. It's one of the most common combinations that you see is a propofol drip with a fentanyl drip.
Or even if you don't have the capability of doing a fentanyl drip, do fentanyl boluses. A lot of institutions are moving towards a analgesia first, sedation and pain control. So the thought process is post-intubation, you would actually provide an analgesic and then start sedation. One of the things that propofol is kind of infamous for is the propofol infusion syndrome. It's originally described mostly in pediatric patients, but it has been case reported in adults. Essentially what you're going to see is acute bradycardia progressing to asystole, plus either they have some kind of metabolic acidosis, rhabdomyolysis, hyperlipidemia, or some kind of larger fatty liver. When it happens fast, and it's almost impossible to reverse. So that's why we don't try to do these max out doses of propofol. Etomidate is the old drug. It has both a good and bad reputation for various reasons. We use it for procedural sedation, for maybe, for example, cardioversions, or maybe very quick reductions for orthopedics. We also use it for induction for rapid sequence intubation. Dosing varies on what you're using it for. Procedural sedation is much lower dose than rapid sequence intubation, and I do recommend giving it over at least 5 to 10 seconds. If you look at the package insert, it will say 15 to 30 seconds. Now, this medication does cause profound respiratory depression. It acts very quickly within a minute to peak effect when you push it, and has a duration about 4 to 10 minutes. So there's a couple things I want to point out about etomidate. Its duration is usually shorter than your paralytic. So when we get ready to do rapid sequence intubation in the ED, I'm already past what drugs we're going to use for induction and intubation. I'm already thinking about what's going to be our plan for analgesia and sedation afterwards. Because there's a good chance, depending on which paralytic you use, your paralysis will last longer than your sedation. And that means you're awake under paralysis. There's a couple things that make etomidate have a bad reputation. One, particularly in procedural sedation, these low doses, it can cause myoclonus, including where your jaw tightens up so much you actually have airway issues in terms of ventilation. So the running joke with that is if you have myoclonus from etomidate, give more etomidate. I don't always think that's the right answer. You could also just, if you can bag them through it, bag them through it. It kind of depends on your ventilation status. The other reason that it has a bad reputation is everyone likes to blame etomidate for adrenal insufficiency in critically ill patients, particularly septic patients. So this is where this comes from. When we didn't have propofol, when we didn't have Versed drips or lorazepam drips back in the day, etomidate was run as a continuous infusion for sedation. When it was used as continuous infusion, yes, we saw profound adrenal insufficiency in these patients, requiring lots of vasopressors. They may need steroids to kind of correct for those things. At a one-time appropriate dose, it's not going to cause prolonged adrenal insufficiency. You will find literature going both ways, and people feel very strongly about this when you go to things like the Society of Critical Care Medicine. You'll have the camp that says never use etomidate in critically ill patients, and then you'll have the camp that says you can use it for a one-time dose. So just know that people do feel strongly about this. So the question is, does etomidate cause hypotension? Etomidate itself, the drug, does not cause hypotension. It doesn't have the mechanism to cause hypotension. But there's the theoretical concept is when you take away someone's respiratory drive, their body's will to keep breathing, to keep up their blood pressure, and they are catecholamine depleted because they're critically ill, When you take that away from them by inducing them with etomidate and a paralytic, their vasculature relaxes, their catecholamines are wasted. That's when you're going to see hypotension. So that's one of the theories why you see hypotension with etomidate. Ketamine. How do I explain ketamine? Ketamine essentially is a PCP derivative. It has profound anesthetic, so you don't remember, and dissociative effect. Dissociative effect means that you are having essentially an out-of-body experience. It doesn't cause respiratory depression when given slowly, and it does help in terms of really bad asthma exacerbations for bronchodilation. They can increase your heart rate and blood pressure, but there is theoretical discussions about it actually being a cardiodepressant in patients who are catecholamine depleted. So if you talk to any anesthesiologist or you go back and read some of the literature from like the 90s and early 2000s, we talk about how ketamine could be a cardiodepressant in very critically ill patients. So don't use your ketamine as a reason to think I'm going to increase my heart rate and blood pressure. It may be negligible, or it may actually be a cardiodepressant.
What about using it in the situation where my patient is hypotensive? Etomidate at this point is probably going to worsen it. I need to, induce them. Mm-hmm. I go to ketamine.
I don't think that's a bad choice. I think that's a completely appropriate choice. As long as you're not IV slamming this in, you're probably going to be fine. We use ketamine potentially for induction, for intubation, and it's called delayed sequence intubation. So not rapid sequence, but delayed sequence intubation. The thought process, because giving ketamine slowly will not take away your respiratory drive. If you IV slam ketamine someone, you will take away the respiratory drive. So delayed sequence intubation, the idea is you give them ketamine, they still have their respiratory drive, and so you can maybe more actively oxygenate them as you're preparing for intubation. So you have more oxygen reserve. Maybe you're making it so they're less acidotic. During that time period, then you can get all your tools ready, or you should have had your tools ready, but you can kind of like give it time for pre-oxygenation. Then you could give your paralytic an intubate. So it's giving you time instead of giving them etomidate and dropping your respiratory drive. It's giving you time to do active oxygenation for pre-oxygenation. So there's a doctor who talks about this in EM Crit. He's the one who coined it and has put it out into the public. There's still a lot more research to be done on it. I'm not saying it's bad. I'm just saying not established yet. Other indications for ketamine are procedural sedation, adjunct pain control, so low dose ketamine for adjunct pain control to try to decrease the overall opioid use, and then excited delirium. So we talk about patients in the field who are out of their mind, incredibly violent, obviously sick and needing help. Recently, within the past few years, there's been articles that come out about intramuscular ketamine. They dose it at 4 milligrams per kilogram, and there might be some variation in some of the studies. That is an interesting set of studies because it comes out and says when we bring those patients to the hospital, a majority of them, and by majority I mean like 25 to 40% of them, get intubated. Now, there could be many reasons for this. One, the physician at the accepting facility does not feel comfortable with the level of consciousness when they come in. But if you really dig into those articles, it's because a majority of the paramedics on those patients that are getting intubated are going straight to the max dose of 400 milligrams IM, and they may be actually giving the patient not 4 milligrams per kilogram, but 9 milligrams per kilogram. And so, we're taking away their respiratory drive or their ability to protect their airway, and yes, those patients are going to get intubated. So if you're going to use this for excited delirium, use it cautiously, do your math, do good weight guessing. Don't just go straight to your max dose. We also use it for procedural sedation, usually in combination with other medications, but it can be used alone. Every now and then you may hear someone using ketamine and propofol for, let's say, a bone reduction. You have an open compound fracture, you want some ketamine because you want that nice, smooth induction into unconsciousness, but you're not quite loose enough, so you use propofol. Now, if you use propofol alone, you have respiratory depression and hypotension. So you use the two of them together to kind of balance each other out. Some people call this ketofol. It's actually been really studied very well. The thought process is whether or not you take the patient too deep into conscious sedation or if you have to provide airway support. And it's not really seemed like it'd be a better agent than any other agent out there. The only thing I ask is that you do not combine ketamine and propofol in the same syringe. When Ketafol came out, I did that. I combined in the same syringe. Lots of errors happened. Nurses and docs don't understand that the concentration per mil, what that's going to look like. So the only thing I ask is that you keep in 2 separate syringes and you ask the doc when you're doing procedural sedation to give you a milligram dosage. Give 10 milligrams, give 20 milligrams. Don't let them just say give 1. What they mean is 1 mil. That means nothing. That's not an order. That's just laziness. Ask for an order. The things you need to watch out for ketamine, I've talked about this a couple times. It can cause severe laryngeal spasms, so that can be really scary when you're trying to intubate somebody. Respiratory arrest if pushed too fast. At least that's our theory so far. I don't think we have a great cause and effect relationship for that. And then emergent phenomenon. This happens mostly in adults. This is when adults are coming out of this PCP high, for lack of a better, way of describing it. And instead of nice fluffy pink elephants like kids see when they're on ketamine, they see the elephants with evil eyes and lasers coming out of their tusks, and they're scared. This can be very scary in air transport, particularly because these patients can start kicking, they try to sit up. The way to avoid this or to treat this after it happens is actually giving a small dose of benzodiazepine. My preference would be midazolam because it's the fastest acting.
Versed.
Yeah, exactly. So some outfits say that you have to give 2 milligrams of Versed if you give ketamine, and others say if you have emergence phenomenon, then you would give 2 to 4 milligrams of ketamine.
So wait for it to happen and then push the...
Yeah, it depends on what group you work with. But I think it would be incredibly terrifying to have a giant biker, that you just picked up off his motorcycle on the highway and you're flying and, he decides to fight. It's amazing the variety of responses from patients on this medication at the 0.1 to 0.3 mg per kg dosing. I think the biggest thing that I've learned from this is infusion related reactions. So our policy now in the ED is not to IV push subdissociative doses of ketamine. We will actually hang it in a 50 or 100 cc bag and let it run over 15 to 30 minutes. So you still have that adjunct pain control of a different mechanism to try to decrease the overall opioid use, but you don't have either the quasi-high, the excited delirium, not excited delirium, but the potential of excitement and putting you into emergence phenomenon. On occasion, you're going to have to use haloperidol or Haldol for patients with delirium, psychosis, or severe agitation. It's actually even a great drug for nausea and vomiting. It works by blocking the effects of dopamine and increases its turnover rate. But let's all be honest, we don't really know the mechanism of a lot of these older antipsychotics. The dose was really varied from 0.5 to 5 milligrams. You may need higher doses for very psychotic, agitated patients. So 5 to 10 milligrams is usually my max out until I know how the patient handles the drug. You can give it intramuscularly even though the vial says not to. Essentially, that comes down to is no one's going to spend the money to go back to the FDA to get relabeled for IM use also. And that's why it still says in the vial not to be given IM. Now, my dosing choices for this kind of depend. I'm not going to give a little old lady who's delirious and sundowning 5 milligrams of IV Haldol. I might give her 1 or 2. Or if I'm using it for nausea and vomiting, I might give just 1 milligram of IV haloperidol. Its onset really varies depending on its administration route. If you're giving it intramuscularly, it's going to take a serious 15 minutes, like a long, dear Lord, why is this not working 15 minutes. Haloperidol gets a bad name because it is notorious for QT prolongation. If you look back at some of the literature in terms of giving haloperidol to a patient without a known EKG or QT length, very rarely will you ever see a patient flip into torsades from a normal dose of haloperidol. But there's patient populations you should think about maybe not using it in to try to prevent some of those things. So I think about patients who are chronic alcoholics who have chronically low levels of potassium and magnesium. That probably puts them at risk for torsades if you give them Haldol. I think about patients that are on other QT prolonging drugs such as methadone. maybe I won't give them Haldol because they're already at a prolonged QT at baseline. And obviously you don't want to give it to patients who have a congenital QT prolongation syndrome.
So let's just briefly gloss over QT intervals. So a QT interval on an EKG, you measure it from the Q wave to the T wave. And the longer those intervals get, the more likely you are to have an R on T phenomenon, which would send that patient potentially into cardiac arrest. And so drugs that prolong QT intervals, you're just putting them at greater risk for cardiac arrest or some type of a significant arrhythmia.
Exactly. It's very tricky, though. What is that magic number? And unfortunately, in EKGs, the number is calculated. It's not an actual measurement. It's calculated by different formulas depending on which one your EKG machine uses. What's also difficult is you have a patient who's tachycardic. By means of the computer inside that EKG machine trying to calculate a QT length, it actually could falsely elongate it because it can't calculate it right. So there'll be lots of times you'll see a pharmacist in the ED holding onto an EKG with the calipers out and actually measuring the QT. And they're like, what's a pharmacist doing with the EKG? Well, we're actually trying to measure it because they're so tachycardic, the machine couldn't calculate it right. What's the magic number to be worried about QT prolongation and adding medications like haloperidol on? It's tricky. So I start paying very strong attention at a QT calculated or QT interval of 500. Some other people will say 480, some will say 460. 500 is when I start getting worried about adding additional medications on with QT prolongation potential. It will depend. And sometimes that's a higher level decision than maybe even a pharmacist or, a transport team gets to make. Maybe that needs to come from the cardiologist. Haloperidol also can cause neuromalignant syndrome, and we will talk about that in a little bit. Olanzapine is one of our atypical antipsychotics. It's relatively newer. It's probably been out within the past 15, 20 years. It acts on serotonin 5-HT and dopamine antagonism, although the exact mechanism is unknown. Get used to that phrase of although the exact mechanism is unknown because it happens a lot with antipsychotics. We're just not sophisticated enough to understand the brain and how these drugs work. We just know they do work. We will use this drug for delirium, psychosis, severe agitation, and sometimes even insomnia in the ICU. You can give it intravenously or sublingually. I think we'll be seeing some literature here pretty soon saying we give it intramuscularly too, but it's not indicated for that yet. And the biggest thing about olanzapine is the orthostatic hypotension. If I gave this to a patient intravenously, I would consider them a fall risk for the next 4 to 6 hours. It could also cause extrapyramidal movements and oversedation. Quintiapine is also another atypical antipsychotic. It has rapid dissociation from the dopamine 2 receptors. So we use this also in delirium, psychosis, severe agitation, and it's been actually studied really well for ICU delirium and insomnia.
We used to give this all the time in the ICU to patients because they need to sleep, and with all the lights on and people coming in and out of the room and their circadian rhythm gets screwed up, and all that stuff adds to the whether or not or how quickly they recover from whatever their illness is. So very common drug in the ICU. And
this is one of those medications, if a patient was on it before their critical illness, if they don't get it, it actually can prolong their ICU stay. So you may see these patients end up with higher doses than the normal critically ill patient. Most of the time, if they've never been on the medication before, we start low and titrate up, and we'll start about 25 milligrams a night. On to our analgesics. The gold standard that everything measures off of is morphine. It is an opioid, and it's a mu receptor agonist. And as you can see from my lovely picture, it actually comes from the poppy plant. If anyone remembers Wizard of Oz when they're going through the poppy fields and they start becoming very sedated, it's because they were insinuating that the opium from the poppy was causing the sedation. So
that movie is trippy.
when you become an adult and know more, it's kind of messed up.
And if you play it in conjunction with Pink Floyd, have you ever heard this?
I've heard this.
I actually tried
Pink
it
Floyd
once.
backwards.
Backwards? I didn't do it backwards.
It's a certain album at backwards, I guess. I don't know if that's true or not.
You might have to be on opium to appreciate it.
Yeah. So if you may see from that poppy pod, they actually score it, and that the latex that come out of there is actually the opium latex. Just another nerdy pharmacist moment. It acts directly on the CNS to produce analgesia. Dose ranges, usually between 2 and 10 milligrams. There's a lot of weight-based protocols that work very well. It just kind of depends on where you work. You can dilute it if you like, and I prefer to give it over 3 to 5 minutes to avoid that hypotension, nausea, vomit, and histamine release we talked about earlier. Histamine release is very common. It's a normal reaction. It is not an allergic reaction. So when patients tell me that they have an allergy to morphine, I ask them to explain it to me. They tell me they start itching or their blood pressure dropped a little bit. That's a histamine reaction. Now, should we still give that patient morphine? Maybe not, but they're not actually allergic to it. And a lot of times just a low-dose antihistamine, it doesn't even have to be IV, it could just be oral Benadryl, will alleviate those reactions. Here's the problem with morphine. It's a dysphoric reaction, so you actually feel badly when you're on morphine. And that's why a lot of patients don't like it. It also has toxic metabolites that build up in the elderly and patients with renal insufficiency. So the morphine 6 metabolite actually can cause delirium. It can cause oversedation. And so I really ask my nurses in the ED to not give morphine more than once in patients over the age of 70. Because they could build this up. So a really good story about this is my grandmother fell and broke her hip. And when she broke her hip, she went to the hospital, went to the emergency department, and they gave her 26 milligrams of morphine. The next 7 days, she was delirious because of the toxic metabolite was built up and she couldn't eliminate it fast enough. So you would then switch over to other medications, maybe a non-opioid, or if you need to stay within the opioid class, you could do hydromorphone or fentanyl. Hydromorphone is also a mu receptor agonist. The dosing can go anywhere from 0.2 to 2 milligrams. So really pay attention to your decimal points on this drug. The reason I have an asterisk next to 2 milligrams is if you have patients who are chronically on opioids and they have a tolerance, you will see, giving 1 or 2 milligrams of hydromorphone at a time. That makes our hospitalists and admission friends crazy because they only write for 0.2 to 0.4 every 6 hours. So they think we're overdosing the patient every time we do this. It's really because we're trying to deal with tolerance issues because we're trying to get on top of their pain while trying to combat their exposure to opioids in the past. It is longer acting than morphine and more potent than morphine. So we think about 7 to 8 milligrams of morphine equals 1 milligram of hydromorphone. It has less histamine release than morphine, but it still does have it, and it's more euphoric than morphine. So patients that may be pain med seeking or coming in for malingering reasons, they love hydromorphone because it makes them euphoric instead of dysphoric like morphine does.
They're allergic to morphine.
Well, yeah.
I can't have morphine. I can't have Toradol. I can't have fentanyl.
Yeah. And usually those patients, and you'll know those patients because they ask for 50 milligrams of IV Benadryl at the same time. Hydromorphone plus Benadryl actually have like a heroin-like high feeling. And so you'll kind of know those patients because they ask for them at the same time and they ask you to push them fast. Fentanyl is one of my baby drugs because I've actually done a lot of research in fentanyl and a lot of its cousins. It's actually synthetic, and it's about 50 to 100 times more potent than its morphine cousin. It's very rapid onset, but unfortunately it doesn't have a shorter duration of action. We use it for analgesia, but we also use it in combination with other drugs for procedural sedation. In flight, in transport, using 25 to 100 micrograms of fentanyl at a time is not unheard of. But if you were in a situation where you were having continuous infusion because they're post-intubation, I would recommend bolusing them up front and then starting a continuous infusion rate somewhere between 25 and 50 to start with, and then titrating up if you need to. If you've ever heard of high doses of fentanyl causing chest wall rigidity, it's pretty much when your rib cage freezes and you don't have that diaphragmatic movement for good ventilation. So unless your patient's paralyzed, their muscle wall freezes and you can't really bag or ventilate them well. And I've only seen this chest wall rigidity happen twice, but one was fatal. So it's enough for me to be like, let's ramp up if you need it. If their RASS score or their sedation score is not adequate, then you can add more. Sufentanil. This is my other favorite drug. This is another synthetic opioid. It is a cousin to fentanyl. It is actually 10 times more potent than fentanyl. The reason why this is important is we actually use it in the surgical world for pain control, and it can be run as an infusion during certain surgical procedures. I like it because an off-label use of fentanyl in the U.S. is you can use it for intranasal dosing. It's weight-based. There's some description about it in the literature, especially in Canada and Europe. They use this a lot more often than we do. But I like it because you may run into some of the ski slopes. Their medical director may actually let their paramedics use this instead of trying to start IVs and everything else. They may be able to intranasally administer pain medications to patients with not multi-traumatic injuries, but maybe just a isolated fracture.
So I don't know if you're going to cover this topic as one topic, but I know there's a lot of confusion in the field about which drugs can be given intranasally and which drugs should not be given intranasally.
So I don't talk about it in this lecture group, but a great reference is intranasal.net. It's up to date with all of the research. In fact, as soon as my research is published, they had it up on their webpage within a couple weeks. They talk about the bioavailability, how whether those concentrations are available in a U.S. market. It's actually a really good resource.
So while we're right here and just talked about fentanyl as an intranasal drug.
Totally possible, especially in children. The problem with adults is the volume you would need for adequate pain control in adults. The volume is too large for the adult nair to absorb. The adult nair can really only tolerate somewhere between 0.5 to 1 mil per nair. And so when you're thinking, the bioavailability intranasally is maybe, I think it's 80%, I believe. You would have to give almost 3 mils of drug for it to be, and that's just too much to absorb. What's nice about sufentanil is at max you're giving 0.5 mil in each nair, and so you actually can absorb that drug. Now, bufene is a drug that you may never see, or it's your workhorse, depending on where you are located and working. It is a mu receptor agonist antagonist, and it does act directly on the CNS for analgesia. Another indication is actually opioid-induced pruritus, and so we actually use this in our patients who are on PCA drips or in our OB unit to try to treat for opioid-induced pruritus.
So this is Nubane, right?
Yes, this is Nubane. Mm-hmm.
That's interesting. I've given Nubane for the pruritus, but I did not know it was a narcotic.
Yes. So it is a narcotic. The dose is usually a flat 10 milligrams. Most people don't deviate away from that. And the dosing is different for pruritus, obviously. Not obviously. I guess some people still give 10 milligrams for the pruritus too. So what's interesting about this, if you have someone chronically on opioids, this might antagonize some of their opioids. Not like naloxone, not like that dramatically, but it could affect them. That being said, it's not a pure agonist, but it still can cause respiratory depression, hypotension, and somnolence. So just something to watch out for, something to monitor for. The tried and true acetaminophen. A lot of people give acetaminophen a hard rap because they say it doesn't work. It's actually an excellent drug as a non-steroidal anti-inflammatory drug and for an antipyretic. Sometimes you would have to use it in combination with other medications as a multimodal approach, but it actually is a great drug. Dosing kind of varies. There's oral and rectal administration. And then just recently, within the past, I want to say 5 years, intravenous acetaminophen has come to market. Now, you will most likely not ride with IV acetaminophen. It's probably going to be cost prohibitive to use in large volumes. And there's actually a lot of hospital restrictions going on across the country. There's been hospitals who've been bankrupted because of IV acetaminophen. It used to be really cheap. You could get it for like $3 a vial, and now it's $37. And there's projected information, it could be as much as $87 a vial. So this should not be your workhorse. Rectal administration, like I said, it's been a administration route for centuries. It actually lasts longer and is more complete. Now, they will tell you that IV acetaminophen is better for various reasons. One, patients like it because it's IV. I think anytime you give IV to someone, they feel some kind of escalated response to it. But what actually is going on with IV acetaminophen and opposed to oral or rectal is it has a higher peak time faster. So it does work faster than oral or rectal Tylenol. Remembering that acetaminophen is the leading cause of drug-induced liver failure, know that your patients may be on combination products and that maybe they've already had their maximum of acetaminophen for the day because they're on combination hydromorphone plus acetaminophen or oxycodone plus acetaminophen. So do recognize that it can hurt more than help. Ketorolac, also known as Toradol, is also an analgesic, and surprisingly to some people, it's an antipyretic. So it's a cousin of ibuprofen, and I don't know if anyone has kids out there, but if they had kids with fevers, a lot of times their pediatricians would recommend alternating between Tylenol and ibuprofen for fever control. It's also a non-steroidal anti-inflammatory drug, and it blocks COX enzymes before it decreases therefore decreasing inflammatory response. Now, dosing, I think we're going to see the dosing recommendations change here in the near future. Intramuscularly, you do need a higher dose because it absorbs so much slower. But intravenously, for years and years and years, we've just given everyone 30 milligrams a dose. There was some great literature that recently was published about giving 15 milligrams. It was actually 10 milligrams in the article, gave the same pain reduction scores and outcomes as 30 milligrams did. So why expose someone to more drug than you have to, especially an NSAID that has prostaglandin induction, because you put your patients at high risk of GI bleeds. So you may see this change. If someone orders a 10 milligram Ketorolac, it's kind of hard because in the US, the vial size only comes in 15 milligrams. So usually I try and negotiate to 15 so nurses don't have to do math and I don't have to do math. This drug is actually a miracle worker in kidney stones also. So the biggest thing about Ketorolac, not everything can be good about it is limited to less than 5 days of use because it does also inhibit platelet function. So between the prostaglandins and inhibiting platelet function, you can put at really increased risk of GI bleed or surgical bleeding. We're starting into our anti-epileptic group now, and we're going to start with the most difficult one to pronounce, the levetiracetam, and we're going to call it Keppra from now on. That's its brand name. It essentially breaks down to it's going to suppress burst firing and propagation of seizure activities. It's indicated for several different situations, including seizure prophylaxis after either brain surgery or a traumatic brain injury. We also will use it for status epilepticus, but it's not our first line. We're still going to use benzodiazepines as our first line medication. It doses somewhere between 500 and 1,000 milligrams. You may hear some people saying loading with Keppra. Essentially, that's going to be 1,000 milligrams, unless they're an incredibly small little lady or a guy, or maybe a pediatric patient. 1,000 milligrams is where we'll start with these patient populations. The thing about this is you can actually free hang this drug, but you can't run it any faster than 150 mgs per minute. So I just kind of will freewheel on a pump set and make sure that I'm running over at least 15 minutes. Now you may start seeing in some of the protocols a high dose load for adults. It's kind of being pulled out of pediatric dosing from 20 to 60 milligrams per kilogram. So don't be surprised if that 1,000 milligram dosing strategy goes away here soon, depending on what the new literature says. Next is phenytoin. It's one of our tried and true medications for seizure and seizure prophylaxis. Its mechanism is due to transdependent blockage of the sodium channel gates. Unfortunately, it does have a lot of drug interactions and is very dependent on patient-specific factors such as their albumin status and their renal function. We'll use it again for seizure prophylaxis after neurosurgery or traumatic head injury. But across the country, Keppra has actually replaced this drug for that indication, just because Keppra has so few drug interactions and isn't dependent on renal function as much. We will use this as one of our second-line drugs after benzodiazepines in a patient in status epilepticus, and actually is probably the first line after the first line, so you may still see this drug quite often. We do load this drug with 15 to 20 milligrams per kilogram, and we can only run it at a rate of 50 milligrams per minute. Unfortunately, this has been labeled that it should not be given peripherally, and if it's being given peripherally, it can actually damage the vessels. So this is the one drug that if you can, you're going to use an alternative. Do not use this drug if the patient's an AV block or bradycardia. And do not use this drug if they're a tricyclic antidepressant overdose. You will actually make it worse and they will continue seizing, and no amount of drug you give is going to reverse that. Next slide. Fosphenytoin is actually the stepson of phenytoin. It is a prodrug, which means it has to lose the phos part of the drug before it can be active. It works the same way as phenytoin. We do also load this drug from 15 to 20 milligrams per phenytoin equivalent, that's the PE, per kilogram. This drug has to be run quite a bit slower and 150 milligrams per minute. I have a little asterisk next to that because I personally run this even slower than that. This drug is notorious for causing an anaphylactoid-like reaction, giving profound hypotension. It's usually fluid responsive and time limited, but it really freaks people out when all of a sudden your patient is 80 over 40 and you have no idea why. This drug can be given peripherally, so it would be the substitute for phenytoin in that situation. If you have a patient who continues to be in status, there is some literature that supports a second dose of another 5 milligrams per kilogram, and you would give that 10 minutes after the completion of the last load. It's compatible with all fluids, but once again, I would not use this drug in TCA overdose because you'll prolong the sodium channel blockade and make their seizures worse. Fosphenytoin is actually the stepson of phenytoin. It is a prodrug, which means it has to lose the phos part of the drug before it can be active. It works the same way as phenytoin. We do also load this drug from 15 to 20 milligrams per phenytoin equivalent, that's the PE, per kilogram. This drug has to be run quite a bit slower and 150 milligrams per minute. I have a little asterisk next to that because I personally run this even slower than that. This drug is notorious for causing an anaphylactoid-like reaction, giving profound hypotension. It's usually fluid responsive and time limited, but it really freaks people out when all of a sudden your patient is 80 over 40 and you have no idea why. This drug can be given peripherally, so it would be the substitute for phenytoin in that situation. If you have a patient who continues to be in status, there is some literature that supports a second dose of another 5 milligrams per kilogram, and you would give that 10 minutes after the completion of the last load. It's compatible with all fluids, but once again, I would not use this drug in TCA overdose because you'll prolong the sodium channel blockade and make their seizures worse. Next is phenobarbital. I'll be very surprised if you actually use this in transport unless you pick up a patient already on a drip. It's a long-acting barbiturate and a sedative. We use it for status epilepticus, tetanus, and we actually use it for coma induction for extreme intracranial hemorrhage and increased intracranial pressure in patients that aren't being relieved by the standard therapies.
So, barbiturate. Talking about barbiturates, this happened once in a bar, and this rhinoceros walked in, and the bartender's there, and there's this lady on the bar stool, and she's just going off on everyone. Bartender, this drink is rotten, and bartender, the peanuts are gone. And finally, the rhinoceros ate her. And he sat there for a minute, and he started to get really, really sleepy. And he turned to the bartender and he said, "Bartender, why am I so tired all of a sudden?" He said, "Oh, that was the barbiturate."
I imagine this happening in Gardner, Montana somewhere.
Probably had. In fact, I think that's actually where it came from. I have that confirmed.
Okay. So now you'll never forget this drug that phenobarbital is a barbiturate. And we're going to use this for status epilepticus. Onset's pretty quick, but the problem is it actually has an extremely long half-life. So we don't use this drug just willy-nilly. We have to have a very specific purpose for us to use it. I would advise you become very familiar with your neuromuscular blocking agents. These are drugs that can really make or break a flight for you, and you need to be really comfortable with them in order to have tools available to you to have a very safe and flight for a patient. So these work by blocking the transmission of neuromuscular signals to the skeletal muscle, essentially resulting in paralysis. We will use these medications for anywhere from rapid sequence intubation, airway protection, ventilator compliance, and sometimes it's because the patient is so combative that even with sedation on board, they won't remember anything, but they're still so hyper that they're going to need some kind of paralysis for safety. My recommendation is to always use capnography when you have a patient on that's paralyzed on and needing ventilation monitoring.
Did you call it captainography?
Captain?
That is your Ohio.
I'm from Ohio. Capnography?
Captain.
Okay. Teach the kids out there how to say it right.
Capnography?
Capnography. It sounds like a boating term. Okay. So how do you know if your patient is still paralyzed? There's lots of different options out there, and then you can look for YouTube videos, or your outfit may have a specific strategy to use. But the one I'm most familiar with is the train of 4 measurement. You can put it on your ulnar, or you can do a facial near your ocular muscles. Your facial ocular muscles. So you can use this before you even start paralytics to see what their baseline response is before starting the paralytics. And then you can also use this medication to see if your paralytics have worn off. This is really important when you have a patient with a traumatic head injury and the neurosurgeon comes in to see if they have any kind of physical response to pain stimuli. And that helps them decide whether or not this patient should go to the OR or not for decompression, for clot removal. So knowing when your last dose of paralytic was and whether or not your train of 4 is eliciting response and your paralytic has worn off is incredibly important in those situations.
Okay, demonstration of train of 4 method. All right, we're going to start. The patches line up with the ulnar nerve. I don't even think we can move this over a little bit. Line up with the pinky. You're going to put one on the wrist area and then one about 3 to 5 centimeters up. So really they're kind of about right next to each other as far as patch placement goes. Okay, and the electrodes, if you can remember, red is closest to the heart. Okay, so red goes here and then black. Okay, and you always want to do a baseline. So before you start your paralytics, you're gonna do this test and find out where they respond at what level. So right now it's on off, and we're just gonna turn it on to 1, and you should see the green light that lights up that the battery is working. There's 4 modes that you can do on here, but we're just gonna do the TOF, train of 4. Okay, so we just hit the button. We're on a level 1. It will give those 4 pulses, and we didn't see anything. We should see the thumb twitch. So you may want to put your fingers in here so that you can feel it and see it. Alright, so we'll turn it up to 2. Hit the button again. And everyone's different. Okay. I responded at a 4, and my husband responded at a 5. We'll see how much Dave can handle. This is a 3. Nothing.
I can feel it.
You can feel it, but we didn't see any twitches.
That's because my nerves are dead.
All right. I'm just going to kind of put my finger here. We see his pinky. Okay. So we're getting there.
Looking for the thumb.
So it has to be the thumb.
We want the thumb. All right. So number 5.
Oh yeah. There you go.
All right. You can definitely see it at a 5.
At 5.
All right.
Jack her up.
So that means when we test his level of sedation or level of paralytics, we want to always use it at that level 5. Okay. So chart that in the computer. Level 5 is what we get the 4 twitches at. So when we do this, to test that we have enough sedation, we want to see, it all depends on what the doctor orders, maybe 1 twitch, 2 twitch. It's usually around that 1 to 2 twitch range. And then we know that they've been paralyzed enough. No twitches at that level 5 means he's probably over paralyzed. Okay? All right. Go ahead and hit stop.
Succinylcholine is going to be one of your workhorses in terms of neuromuscular blocking agents. It is a depolarizing NMDA, and it agonizes the nicotinic receptors. What it's going to essentially happen is it prevents neuromuscular transmission by blocking the effect of acetylcholine at the myoneural junction. When you have that agonist activity, you actually produce a muscle fasciculation. So you may see your patient's toes, their hands, if they're really muscular, you might see like their pecs even start twitching as the muscle depolarizes. It has no analgesic or anxiolytic or sedation effects. So because of this, you have to put some kind of sedation along with this so your patient's not awake under paralysis. The general dosing is 1 to 1.5 mg per kg. I recommend 1.5 only because then you have more drug to get to the receptors, so you have a faster onset of your medication. This drug's very short acting and it comes off very quickly, so I'm not worried about giving the patient too much drug. Succinylcholine's onset is about 30 seconds. If you dose them appropriately, you'll actually see it sooner than that, but you won't see a total paralysis until about 45 seconds. The duration is pretty short, about 48 minutes. So I would be prepared with making sure you have sedation and anxiolytic pain medications ready to go within that time, and also making sure your airway is secure during that 48 minutes. And then finally, if you need to have some kind of restraint on the patient, make sure you have restraints on within that 48 minutes. Because if not, they may wake up very angry and start pulling at things. There are contraindications for succinylcholine, and that's why it's not your only tool in your toolbox. I don't think that this happens immediately after you give the drug, but it does have some potentiation for issues later. There are certain patient populations that using succinylcholine is contraindicated in, so that's why it's only one tool in your toolbox. I do not use this medication in patients that have any potentiation of having hyperkalemia during their disease state. So that would include patients like large burns, crush, potential rhabdomyolysis, like you find a patient that's been down for an unknown amount of time, patients with acute spinal cord injuries, or renal failure. The reason is succinylcholine theoretically will increase extracellular potassium levels somewhere between 0.6 and 1.2 milliequivalents. So we do worry about causing hyperkalemia in patients during their critically ill time. If you come up on a patient that has a fistula, for example, I would automatically assume they have the potential to have hyperkalemia. Now, this doesn't happen acutely. Everyone thinks that you're going to push succinylcholine and all of a sudden you're going to have arrhythmias because of hyperkalemia. It actually happens over a 24-hour period. So if you accidentally or unknowingly give succinylcholine to a patient and find out after the fact they have renal failure or they do have rhabdomyolysis, just let the accepting team know so we can monitor and adjust for it during their stay. The biggest thing you need to worry about succinylcholine, and it happens so rarely I'm actually hesitant to talk about it, but you really should know about it, is neuroleptic malignant hyperthermia. Neuroleptic malignant hyperthermia, or we can call it NMS, it's a potentially fatal hypermetabolic state of the skeletal muscle. It kind of presents as intractable spasms of the jaw muscle. That may be one of your first signs, and it just kind of looks like general rigidity. You're going to have a patient, you think you're ventilating very well, you got them hooked up, you know you're not right main stemmed, you have a good airway, and all of a sudden they become incredibly hypoxic out of nowhere, and you're trying to figure out what's wrong. They become tachycardic and tachypnic, and you're going to eventually find out that they have a really high fever. So the signs of this would be the rigidity and that extreme oxygen demand that happens out of nowhere, and you're trying to problem solve why. That should be the trigger in your head to think, oh, am I dealing with NMS? Now, outcomes of this really depends on successful recognition of this disease state. If you don't catch on to this and they just keep crumping, you're going to have poor outcomes. So what you need to do is you need to make sure you discontinue any anesthesia that you may be giving. So that would be on the inpatient side. Make sure that you are giving the increased oxygen to meet their consumption. Correct acidosis if you can, or you know what your acidotic level is. Make sure you support circulation. You may have to start vasopressors in these patients. Make sure you have adequate fluids going on, and then if they have extreme temperatures, treat it with an antipyretic. Ultimately, the fastest treatment is dantrolene, but because of cost and reconstitution issues, there's not going to be a possibility of that being in transport. The other big workhorse in the neuromuscular blockers is rocuronium. It actually is a non-depolarizing paralytic, so you're not going to see that fasciculation you see in succinylcholine. It's fastest onset of all of the non-depolarizing paralytics. And this is a drug that I also will dose towards the higher end, at least 1 milligram per kilogram, because this onset of this drug seems like it takes forever. It's funny because in my emergency department, we'll sit there and we'll count kind of under our breath, but we'll count to kind of remind the resident or the intern who's doing the intubation procedure that you can't just start tubing them because their paralysis is not on board yet. So I would recommend waiting 30 to 45 seconds, making sure you have good paralysis before you start your procedure. This drug does last quite a bit longer than succinylcholine. This can last for 45 minutes. And if you remember from our sedative portion of this lecture, etomidate, if you use that for intubation, only lasts about 8 minutes. So you have an extended period of time of paralysis without sedation. So if you're choosing or you're assisting someone who's choosing rocuronium for their intubation paralytic, you should have a timeout and discussion what sedation is going to be like after the intubation procedure is completed before starting. There are the possibilities of giving bolus doses during transport if you need to, if you're getting in, bad situations where they're starting to move too much or they're not compliant to the ventilator. And you can have a half a milligram per kilogram to kind of supplement as time goes on. And then finally, there are continuous infusions of rocuronium. I've actually not seen this in over a decade, so I'm not sure if anyone still does them, but there is a rate there in case you need it. This drug is also refrigerated for storage, but it is good outside the refrigerator for 60 days. So when you take it out of the refrigerator for the first time, remember to label it. These are 4 other paralytics you may see in your practice. The only one you may use commonly is vecuronium. We use this in our emergency department for prolonged imaging after intubation, like 45 minutes worth of MRIs. But the other ones you may only see in critical care unit situations.
All right, that does it for neurological medications. We have one more lesson in this series, and then you'll be done with this pharmacology section.